Yeah.
So it's from Dr. Doyle, but I think it's more of a general case that he kind of came up with, where he's looking for strategies to communicate with basically a colleague, another physician who's experiencing back pain, I believe, from falling off his bike and hasn't been getting treatment. So his questions are, so as a physician with a colleague that is a physician as well, what advice do you recommend on approaching the situation? It's kind of he made up the case, I'm pretty sure, because when I first read it, he's an avid bike rider and everything, so I thought it was him, but it's not, because he's not 45. So it's really just to get some kind of tips if anybody's ever had to deal with that before. And we'll obviously share them with the group. That's what he would like, and we can have a discussion about it. I see we have a couple people jumped on. Do they want to go ahead and introduce themselves first? Hey, Carmen.
Hi.
Want to introduce yourself to the group?
Oh, Carmen Rexstrode, family doc at Pendleton Community Care in Franklin.
Awesome.
Perfect, thank you. And Dr. Fournier, we saw you jumped on as well.
Yeah, Dr. Kelly Fournier, family practice, Weirton.
Perfect, thank you.
I think somebody joined. Did somebody join from the pain clinic? I see another person there at the pain clinic.
Julianne Sweeney, exercise physiologist.
Awesome.
Perfect.
Okay. So does anybody have any initial thoughts kind of walking through this situation rather than a case, about how to approach somebody who's had a lot of experience as a family physician, and who is essentially ignoring his pain or ignoring his injury, and just kind of taking NSAIDs here and there, stretching. Has anybody ever dealt with that kind of situation with a colleague of theirs?
Some of us.
So was Dr. Doyle's, this is not actually a patient being seen, it's just somebody that you work with, and his question is, how do you approach him? Is that, or is this person a patient?
To me, it sounded like this is a patient that this person is seeing another provider.
Yeah, can you go back to the questions at the bottom? That was helpful.
Sure.
Yeah, I think you're right.
Yeah.
And can you guys scroll back up a little bit to see the physical exam? So he has been a patient,
Well, again, me not obviously being a psychiatrist or a psychologist, one of the things that, I'd be curious to know why he actually came to be seen, because, I mean, it's obvious that he's being seen as a patient as opposed to as a physician, and he's desperate about his condition. So I think one would have to pursue, where he's at with respect to, his pain state, which is by definition not chronic at this point, but still of considerable distress with him based on his assessment tools with respect to him being depressed, and his pain rating scales are obviously, this is of great concern to him. And so I'm just curious as to why he's desperate. And also, what actually he has done with respect to managing his pain, either therapeutically with drugs, or, how successful and how adherent really has he been with some of these techniques to try to alleviate his back pain. So that's perhaps where, at least that's a place to maybe start.
This is Jen. I would, can you show us those pain rating scales? Well, there's kind of a lot of things in this case on paper. There's the story of his pain. There's the story that he looks anxious and tense, and I don't know where 110 on the Maslach burnout inventory is, but it sounds high. There is, as you just said, Dr. Pondy, there's the PHQ-9 and the GAD-7. There's his blood pressure, you know, and he's using NSAIDs daily. I would, one thing I would do, and I would just be curious to know from the pain center providers, I would check, I'm in the habit of checking the psoas muscle for people with back pain, including people with sciatica. And so I would check that. I would, and if that were tight and sore, I would show them a stretch for that. I would want to know how has physical therapy helped him. And then I would try to approach this, these issues of depression and burnout and anxiety, and see if I could sort out the chicken from the egg there.
I guess the other thing that just struck me is the real issue here, not so much the back pain, but it's the exhaustion and the burnout and the depression.
Right.
And that may well be the issue, but getting this guy to admit that that's the issue may be an issue. Maybe an issue.
Right.
Did anyone over at the pain clinic have any comments or, you know, based on what Jennifer had said as well?
Generally, if I see a colleague or some other type A individual, I outline potential treatment and then let them select what they might accept and not accept. Because they're never going to listen to you if you say, you need to do this or that. So you could say, what we normally do would be these things. You tell me if you're interested in one or any of them, and I'll help you get it done. Unfortunately, the one thing you need to understand, and it's not as, may not be as easy to do as it was in the past, these are the types of individuals that become drug dependent. So it'd be real easy for this guy to start prescribing himself or getting someone to prescribe him some pain medication, which would be a terrible mistake. And I've heard stories of people who were detoxified who, the majority of them would have this same history.
Thank you for that.
I'll add for the psychiatric component, you know, his PHQ-9 is certainly concerning for depression, and you know, pain is exacerbated by low mood, you know, and they tend to co-occur, but the perception of pain is more prevalent in people who are depressed. I don't know how to interpret the burnout score. I've not seen that before, but that can go along with depression also. And I can't speculate about what medicine I would use necessarily. You'd want to know if he had atypical features or melancholic features. If you wanted to help with the neuropathic component of his pain and depression and anxiety, you might use an SNRI or a tricyclic antidepressant. But he needs a psychiatric assessment probably.
But if he's like a lot of us, the neuropsychiatrist that you might want to see is 3 hours away, means taking a whole day out of the office. You know, is he going to do that?
Good point.
Well, does he need a neuropsychiatrist? Where's the indication that it's beyond primary care at this point?
Yeah, I don't know what the cutoff is for what someone's comfortable with from a primary care standpoint, prescribing for treating depression, but there's not enough information here to know what you need to do.
Yeah, I mean, just based on the face of it, I would be definitely comfortable talking to him about it and seeing if he were interested in treatment.
Yeah, so I just say, look, you know, if you're suffering, why not do what we can to improve your situation? And, you know, there's a biology to this, right?
The
Another
other,
thing that's coming down the pike is they're working on telepsychiatry at WVU so that we'll be able to reach rural locations through telemedicine in the psychiatry department. So I don't know if that's available where this guy would be located, but that might be an option for someone who didn't want to travel.
another thing that's interesting in this story is that, you know, it sounds like his accident was a pretty drastic change in his leisure activities, and I would want to know if he's getting any physical activity, because all of that could certainly be leading to the depression, and maybe working with him on if you were interested in somehow getting back some physical activity and doing formal PT instead of just informal advice. Obviously, all of that, what he's willing to do.
So we have the current medication list there, but I would also add in that it says that this, we presume gentleman because of men's multivitamin, but that this guy says he's working a 70-hour work week. So in my left hand, I have what I use, caffeine, and then I have Scooby Snacks. And it's the gummy thingies, it's not the synthetic marijuana. Just for that point, since a couple people are calling me out on that here. Throwing that out there. But one of my questions to this guy would be, you know, how are you sustaining that? How much caffeine is going into that blood pressure? What's going on with that? Just in case there's anything else, and it's not necessarily illicit or anything, that's why I was using the coffee cup there. One little random thing, and this is extremely nitpicking, but since Charlie's got two PharmD candidates there, I'll throw this question to them. But if you're looking at those current medications, there's only 4. And the first 2 are OTC. Is there anything that stands out as far as the OTC dose on that? I'll say naproxen.
It's a little bit high for an over-the-counter dose.
Is it even available?
No.
Correct. Yay, we're doing something up there. Well done, Laura and Nicole. So OTC naproxen is 220, yet it's written 500. So again, that's an extreme nitpick, but I would be wondering if they're already at the point of using a pad, a script pad, and then that would go into what Rick was saying earlier of that, down that path. So that's it. Back to my Scooby Snacks.
You know, again, I think one has to also look at the relationship between him and his wife and the kids issue as well, and see what impact that is also having on him. I mean, there's a whole sort of biopsychosocial dynamic here that I think has to be addressed. You know, that you know, beyond just the physical manifestations of his complaints. You know, and you know, is he over medicating with the naproxen? Is that obviously influencing his blood pressure? Which obviously it could, but you know, so I think there's so much more to him than just back pain. That's to me is the real crux of the issues. And frankly, I think, you know, it's however you decide to do this, gingerly, you're going to have to assess whether or not he has suicidality.
Oh yeah, good point. It's a good
Just
sign
because
that
some of the terms like he's desperate, you know, and those are things that, you know, I think are red flags that you have to give some thought to as being a potential, you know, issue for him, you know, and that, you know, may require either addressing it if you have that concern, or somehow a triage to another provider or mental health professional. But, you know, I think there's so much here that's, you know, potentially a problem.
Just to mention about kind of cardinal terms that you should watch out for, hopelessness is a very poor prognostic sign for somebody who's depressed and maybe suicidal. So, if they're saying they're hopeless, that should be an alarming kind of thing they would mention. Desperate's kind of more common and just
Right.
it's urgent to be addressed, but hopeless really makes me worry.
Okay.
It's a good sign that he asked for help, I think, from a colleague.
That was all really great. Thank you guys. I know this was sort of different from our typical case presentations, but before we move on, I wanted to ask if anyone had any other comments or questions, similar patient cases you've seen at your location. You guys are welcome to make comments as well if you have any.
I wanted to just go back to my question about the psoas muscle and particularly to the chiropractors at the pain center, if you ever assess that in people. I find that, you know, this guy's depression and the psychological issues aside, when I can find that somebody has psoas tenderness and teach them a stretch that's effective in relieving that, I have found in my practice that it really gives a tremendous psychological boost to people with back pain.
Yeah, the psoas muscle is a part of our common workup. It's commonly tight in a lot of people. We live in a society where we sit a lot, so our hip flexors are prone to getting tightness. You can dive deep into the neurology and find that the psoas is also prone to tightness from a neurological perspective as well. And so it will affect function of the lumbosacral area. So any kind of stretching for that can sometimes be very effective for people. People with more complicated back pain might need more than that to kind of address, you know, the totality of the muscle imbalances. But if you show somebody a simple psoas stretch and they're feeling great, then run with it. Julianne, anything to add, or Ed?
Got it. Hit the nail on the head.
I think a candidate like this would probably be a good option for more non-drug measurements. So just looking at the fact that he's from a rural area, I assume that he probably sees, I don't know if it's in West Virginia, but WVSOM, he probably sees his share of drug addiction and sees his share of, you know, drugs that are used in that case, which probably makes him more hesitant to use any type of drug. So I don't know if he would technically be a candidate that we would worry about him, you know, over prescribing for himself or trying to prescribe a C2 or anything like that in this case, or drug seeking, because I'm sure he probably sees his share of it being in a rural practice.
Sure.
Yeah, I guess along those lines, you of course would want to get an addictions history and, you know, see if he's ever dabbled in any substances or has any use patterns or consequences of use in his life.
Thank you, everyone. And if you guys have any further questions or comments about this, I can, you know, shoot me an email or you can chat us on the side as well, and I'll make sure to have them addressed and send them back to you. So thank you guys for that.